Okay, so time to talk about tubular reabsorption. There's two different types of reabsorption. We're going to focus now on reabsorption via the transport maximum system. And when we talk about reabsorption via the transport maximum system, we use glucose as the prototypical example. Now we're going to focus on glucose, but realize that most substances that are reabsorbed via the transport maximum system. So let's take a look at how reabsorption works in the proximal tubule. So if this is the lumen, and here's the luminal membrane, you have glucose that was filtered. In the basolateral membrane, you have the sodium-potassium ATPase hydrolyzing ATP to actively reabsorb sodium. That sets up an electrochemical gradient for sodium. Then you have the SGLT2 channels, which stand for sodium glucose co-transporter. These co-transporters will co-transport sodium and glucose. Sodium will move in the cell down its electrochemical gradient. As it does so, it will co-transport glucose. This is an example of secondary active transport. This is how glucose is reabsorbed in the proximal tubule. Now, remember saturation kinetics. And now when I say the concentration of glucose in the lumen increases, what I'm really saying is the filtered load. Because that's what I'm talking about. The concentration of glucose in the lumen of the proximal tubules is the filtered load. So as the filtered load of glucose increases, meaning the concentration of glucose, the rate of reabsorption of glucose increases. Again, as the concentration of glucose in the lumen of the proximal tubules increase, the rate of reabsorption of glucose increases until the SGLT2 carriers get saturated. And they do. At some point, the SGLT2 carriers become saturated. Now, once they become saturated, you continue to reabsorb glucose, but you reabsorb glucose at a constant rate. That constant rate of reabsorption of glucose is known as transport maximum. So, again, transport maximum is a constant rate of reabsorption of glucose. That's what transport maximum is. It is a constant rate of reabsorption of glucose. This occurs once the SGLT2 channels become saturated. And you continue to reabsorb glucose, but you continue to reabsorb glucose at a constant rate. Okay, tubular reabsorption. This is probably the most important graph you're going to see in all of renal physiology. So let's spend a few minutes on this graph. So, like any time you see a graph in physiology, the first thing you're going to do is look at your x-axis and look at your y-axis. So the x-axis is a glucose concentration in plasma. And again, always look at the units, milligrams per milliliter. You could also look at this in milligrams per deciliter, but I think most of the graphs on step 1 will give this to you in milligrams per milliliter. So that is the plasma glucose concentration. That's the x-axis. On the y-axis, looking at the glucose rate. Rate of what? Well, again, we're going back to mass balances. What we're looking at here, what we're graphing here, is the mass balance equation, which is the following. Excretion rate is equal to filtered load minus reabsorption rate. Once again, excretion rate is equal to filtered load minus reabsorption rate. What we're doing here is we're graphing mass balances. So let's break this graph apart and look at it one by one. When you look at it like this, it looks very complicated. But if you look at it piece by piece, it's not so complicated. First, let's tackle the filtered load. Well, we know that filtered load is equal to GFR times plasma glucose concentration. So, if we keep the GFR constant and we increase the plasma glucose concentration, what happens to the filtered load? Well, it increases exponentially. And if you look at the graph, you can see the line that's labeled filtered, that's the filtered load. As the plasma glucose concentration increases,
the filter load increases exponentially. And you can see, look at a glucose concentration of 6, for example. At a glucose concentration of 6, you can see that your filter load is very high. Okay, maybe it's around 800, based on this graph. So the higher the plasma glucose concentration, the higher the filter load is. And that's the filter load. So that's the first thing that we are graphing. Second thing we are graphing is the reabsorption rate. Now, as the plasma glucose concentration increases, the reabsorption rate increases. Now remember, the channels that are responsible for reabsorption of glucose in the proximal tubules are the SGLT2 channels. Now the SGLT2 channels are very important channels in renal physiology. These are the channels responsible for reabsorbing glucose via secondary active transport. So let's take a look at reabsorption. When you look at reabsorption of glucose, it is the SGLT2 transporters that are responsible for reabsorption of glucose. Remember how the SGLT2 transporters work. These are specialized transporters, or carriers, that reabsorb glucose via secondary active transport. As glucose goes inside the proximal tubule cell, down a electrochemical gradient, it uses that energy to pull glucose into the cell with it. And this is how glucose is reabsorbed via the SGLT2 carriers. Now, it is the SGLT2 carriers that get saturated. At low or normal plasma glucose concentrations, you filter glucose and you reabsorb glucose. Well, as the plasma glucose concentration increases, the filtered load increases. As the filtered load increases, the rate of reabsorption via the SGLT2 carriers increases until they become saturated. Remember, that is saturation kinetics. Once the SGLT2 carriers become saturated, you reabsorb at a constant rate. Now, you don't stop reabsorbing, but you reabsorb at a constant rate. Now, T on this graph stands for the plasma or renal threshold, and that's a very important value to understand. The plasma threshold, or the renal threshold, is the plasma glucose concentration at which the SGLT2 carriers first become saturated. Once you start to saturate these carriers, glucose is excreted, or glucose makes an appearance in the urine. Notice before T, what is the excretion rate? It is 0. Because before T, before the renal threshold, all of the glucose that is filtered is reabsorbed, and the excretion rate is equal to 0. Once you hit the renal threshold, you start to saturate the very first SGLT2 carrier. Once that happens, you start to have an excretion rate. Now, if you take a look at the reabsorption line, you can see that once you hit T, that line starts to bend. And then you see that curvature. We call that splay. Splay is a region at which some of the SGLT2 carriers are saturated, but not all. Splay is a region at which glucose is excreted in the urine, but not all of the carriers are saturated. Transport maximum. Transport maximum, remember the definition, very important definition to understand. Transport maximum is the rate of reabsorption at which all of the carriers are saturated. Once the carriers are 100% saturated, you don't stop reabsorbing, you continue to reabsorb glucose. However, you are reabsorbing glucose at a constant rate. That constant rate of reabsorption is 375 milligrams per minute. That is the definition of transport maximum. Now, the exam might try to get you confused between transport maximum and renal threshold. Remember your units. Remember your definitions. Transport maximum is a rate. It is a rate of reabsorption. Therefore, the units will be milligrams per minute. Renal threshold, that's the concentration. That's the plasma glucose concentration. Therefore, the units will be milligrams per milliliter. So transport maximum is a constant rate of reabsorption. You can see by this graph, that number is 375 milligrams per minute. That is transport maximum. Now let's go back to splay for a minute. The exam is big on you knowing the difference between splay and transport maximum. Splay is a region at which some of the carriers are saturated, so there will be an excretion rate of glucose, number one. Number two, you are not 100% saturated. You are not at transport maximum. So therefore, you can see in the graph, as you increase the plasma glucose concentration, you will see an increase in the rate of reabsorption. Now, they may give you a question on the exam where they tell you a patient has glucose in the urine. If you have glucose in the urine, you must be past the renal threshold, but then they'll tell you that as you increase the plasma glucose concentration, you are increasing the rate of reabsorption. You must be in SLED. You cannot be reabsorbing at transport maximum, because at transport maximum, you are 100% saturated. So that is the line for reabsorption. Excretion rate, as you can see, is the blue line. Before the renal threshold, rate of reabsorption is 0, and then, once you are past the renal threshold, you have an excretion rate.
One more question they love to ask on this graph is a calculation. Again, they'll commonly give you the graph of reabsorption rate, and they'll say, at a plasma glucose concentration of 5, calculate the excretion rate. What do we know about the excretion rate? We know the excretion rate is equal to the filtered load minus the reabsorption rate. We know the filtered load is GFR times plasma glucose concentration. GFR is 120 milliliters per minute. We're assuming normal GFR for these equations. So therefore, your filtered load is going to be 120 milliliters per minute times 5 milligrams per milliliter. Your filtered load comes out to be 600 milligrams per minute. That's your filtered load. At a plasma glucose concentration of 5, what is your reabsorption rate? You are reabsorbing at transport maximum. Therefore, the answer is the reabsorption rate is 375 milligrams per minute. So now the excretion rate is going to be 600 milligrams per minute minus 375 milligrams per minute. The excretion rate will come out to be 225 milligrams per minute. So getting this question right relies on two things. Understanding the excretion rate is equal to filtered load minus reabsorption rate. And you have to know how to calculate the filtered load. But you also have to realize that at a plasma glucose concentration of 5, you are reabsorbing at transport maximum, and the reabsorption rate that you are going to use to calculate this equation is transport maximum, which is 375 milligrams per minute. Another thing the exam will do is try to confuse you between transport maximum and the renal threshold. Remember your units. The renal threshold is a plasma glucose concentration. Has to be in milligrams per milliliter. Transport maximum is a rate of reabsorption. Has to be in milligrams per minute. Okay, so excretion rate, that's the last graph I want to look at. Excretion rate starts at the renal threshold. Before the renal threshold, there is no excretion rate. It starts at the renal threshold, and then it increases. Okay, so let me give you some examples of what they'll give you on step 1. What they're likely to do is give you the graph of reabsorption. They'll give you the graph of reabsorption, and they'll give you some letters on the graph. Let's say you have a letter D over here and a letter E over here. And they'll say, as the patient goes from point D to point E, what will happen to the excretion rate? Well, remember, excretion rate is equal to filtered load minus reabsorption rate. Well, as you go from D to E, you have an increase in the plasma glucose concentration. The filtered load is equal to GFR times plasma glucose concentration. Well, if you're increasing the plasma glucose concentration, the GFR is constant, you're increasing the plasma glucose concentration, the filtered load increases, but remember, at that point, if the line is flat, what's your reabsorption rate? It is constant. It is transport maximum. So, if you're increasing the plasma glucose concentration, you're increasing the filtered load, but the rate of reabsorption is constant because you're reabsorbing at transport maximum, the answer is the excretion rate must be increasing. You see, if you're filtering more glucose, but you're not reabsorbing more glucose, where does it go? It's not disappearing. It's not a magic act in Las Vegas. You must be excreting more glucose. You have to increase the excretion rate of glucose. That's a famous question they can ask you. So be familiar with these types of questions. One other thing step one loves to ask about is pregnancy. So in pregnancy, there is an increase in the cardiac output, and that increase in cardiac output leads to an increase in GFR. In pregnancy, there is an increase in GFR. That's important to know. Your filtered load is equal to GFR times plasma glucose concentration. So therefore, because there's an increase in GFR, you get an increase in filtered load of glucose. Well, the SGLT2 carriers, guess what? They get saturated based on the filtered load. So here's what happens in pregnancy. Your SGLT2 carriers, they get saturated at a lower plasma glucose concentration. Therefore, what you see in pregnancy is you see a decrease in the renal threshold, meaning that the SGLT2 carriers get saturated at a lower plasma glucose concentration, meaning that there's an excretion of glucose in the urine at a lower plasma glucose concentration. So in pregnancy, you very commonly see glucose in the urine, and that's why the obstetrician commonly checks the urine to make sure that there's no UTIs, because you get frequent UTIs due to this effect. So again, the carriers get saturated at a lower plasma glucose concentration, and there's an increase in the excretion of glucose. So you commonly see glucosuria in pregnancy due to the lower renal threshold. It's a common question. They like to ask that on the exam. This is a high yield question. Okay, and that's a lot of the types of questions you will see based on reabsorption of glucose. So the SGLT2 carrier is now a drug target for type 2 diabetes. There is a new class of drugs called the SGLT2 inhibitors that are now used to treat type 2 diabetes. The first drug is canagliflozin. I did not make this name up, so don't get mad at me. It's a wonderful name. So this is the first drug, and you'll see many drugs come out after this. This inhibits this carrier, and this leads to an increase in the excretion rate of glucose, and that leads to a decrease in your hemoglobin A1C. And there's some weight loss with this drug. I'm sure you can imagine the big side effect is urinary tract infections and yeast infections and osmotic diuresis. So these carriers are now drug targets for type 2 diabetes, so therefore they will be tested more and more commonly on the exams. So we spoke about reabsorption. Now it's time to talk about secretion. So when we talk about secretion, we always talk about pAH. pAH is used in experiments to study secretion. It's a non-natural substance that is injected in patients. It is freely filtered. It is secreted. So let's take a look at pAH. So you have a renal plasma flow, which is a volume of plasma that enters the kidneys. And in that volume of plasma is a concentration of pAH. And usually there's a low concentration of pAH in that renal plasma flow. Now, we said earlier that the filtration fraction is 20%, and that's still true here. 20% of that renal plasma flow will be filtered, and therefore 20% of the pAH will be filtered right here at the glomeruli. The other 80% will be secreted at the peritubular capillaries. So 20% is filtered, 80% is secreted, 100% is excreted, 100% is cleared.
If you look over here at the renal vein, you will see in the renal vein the plasma concentration of PAH will be 0. That means the clearance is very high. That means you have cleared everything that has entered the kidneys. 20% filtered, 80% secreted, 100% excreted, 100% cleared. Your clearance is 100%. Your clearance is the renal plasma flow. Therefore, in experiments, we use the clearance of PAH to calculate what we call the effective renal plasma flow. You will be questioned on this in the exam. They will ask you to calculate the effective renal plasma flow. Now, I use the word effective because it turns out that not the entire renal plasma flow goes to the glomeruli. 10% goes to perinephric fat and the renal capsules. So that 10% actually doesn't get cleared. So 90% of the total renal plasma flow gets cleared. So that's why I'm using the word effective. So if they ask you to calculate the effective renal plasma flow, you are going to calculate the clearance of PAH. And that's a question that they might give you. So let's take a look at how we could do that. So here's a nice question they can ask you. They can ask you to calculate the filtration fraction. And remember, we said filtration fraction is equal to GFR over renal plasma flow. GFR, we haven't calculated yet, but I'm sure you know, to calculate GFR, we will use the clearance of creatinine. And for renal plasma flow, we will use clearance PAH. So they will give you these values in the question. So to calculate the clearance PAH, they will give you the urine concentration of PAH times the urine flow rate over the plasma concentration of PAH. You will use this equation to calculate the clearance of PAH. Then you will calculate the GFR using the creatinine clearance, or you can also use, you'll see a little bit later, the inulin clearance, and then you can use both numbers to calculate the filtration fraction. And that's a common question they can ask you. So again, if they ask you to calculate the renal plasma flow or the effective renal plasma flow, you will use the clearance of PAH. So this is a common question that they might ask you on the exam. Now, another thing they will ask you on the exam about PAH is what happens as you increase your plasma concentration of PAH. Now, this is a very important concept to talk about. As you increase the concentration of PAH in the renal plasma flow, here's what happens. The filtration fraction is 20%. You will always and forever filter that 20%. And guess what? The 20% you filter, remember, that 20% is not reabsorbed. Therefore, that 20% is excreted, that 20% is cleared. So that 20% is removed from the plasma. You will always clear that 20% that is filtered. That does not get reabsorbed, so that's cleared. Now, what happens to the 80%? Well, remember, secretion has carriers. Secretion has carriers in the cells of the proximal tubules. These carriers get saturated. These carriers do have a transport maximum. So what happens when the PAH carriers become saturated? Well, when they reach transport maximum, you're now secreting at a constant rate. So let's talk about what happens. What happens when the PAH carriers are saturated? What happens when you reach transport maximum and you're secreting at a constant rate? So let me give you some numbers. Let's say, for example, you have 10 molecules. So let's use some numbers. Let's say you have 10 milligrams of PAH in the renal plasma flow. 10 milligrams, that's it. That's a low concentration. You will filter 2 milligrams. You will secrete 8 milligrams. You will excrete 10 milligrams. You will clear all 10 milligrams. You will clear the entire renal plasma flow. The renal vein will have 0 molecules. Your clearance is very high. Your clearance is the entire renal plasma flow. Now, let's say you have 1,000 molecules of PAH entering the kidneys. Your renal plasma flow now has 1,000 molecules. Well, you're still going to filter 20%. That's constant. You're now going to filter 200 milligrams. You now have 800 milligrams left at the peritubular capillaries. But your transport maximum is 80. You don't have to know that number. I'm just giving you an example. Your transport maximum is 80 milligrams. So now you're at transport maximum. You are only able to secrete 80 milligrams. And you do. You do secrete 80 milligrams. What happens to the 720 milligrams? They are not secreted. They are not cleared. So now my renal vein now contains 720 milligrams of PAH. So what just happened to my clearance? My clearance went from very high, my entire renal plasma flow, to very low. My clearance just decreased. I just had a very big drop in my clearance because I'm secreting at transport maximum. My carriers are saturated. I can no longer clear my entire renal plasma flow. So I see a very big decrease in my clearance. Now if I calculate my clearance, well, I cleared out of 1,000 molecules that entered the kidneys in my renal plasma flow, I no longer cleared that renal plasma flow. I only cleared 280 milligrams. Out of that 280, where did most of them come from? Did most of them come from what was filtered, or did most of them come from what was secreted? Well, 200 came from filtration and only 80 came from secretion. Therefore, most of what was cleared was filtered. So now if I calculate the clearance, I'm estimating what was filtered. I'm estimating the GFR. And this is why we use creatinine to calculate, or I should say to estimate, GFR. We always have a high concentration of creatinine entering our kidneys in the renal plasma flow. We're always filtering 20%. We're always secreting the transport maximum. So most of the creatinine that our kidneys clear is what is filtered. And only a small amount of what our kidneys clear is the transport maximum, which is what is secreted. And this is why we use creatinine to estimate GFR. But realize I use the word estimate. It's not an exact number because we are overestimating the GFR by a little bit because we have that little bit that we're secreting. That's the transport maximum. And that's why we use creatinine to estimate GFR. So it's the same concept as high concentrations of PAH. Okay, so to summarize, we use PAH to estimate the renal plasma flow. At low concentrations of PAH, all the PAH that enters the kidneys are removed and excreted in the urine. And when PAH concentration is below transport maximum, we use PAH clearance to calculate the estimated renal plasma flow. So we say this is the effective renal plasma flow because about 10% of this flow is not cleared, because 10% of this flow goes to the renal capsule and 10% goes to the perinephric fat. So pH clearance is only 90% of the true renal plasma flow. And that's why we use the term effective renal plasma flow. As the plasma concentration of PAH increases, the clearance of PAH decreases. Once again, this is because the carriers that secrete PAH become saturated, they have a transport maximum, and once they reach transport maximum, PAH is secreted at a constant rate,
and the rest of PAH, any PAH that is past that transport maximum, is not secreted. If it's not secreted, it's not cleared. Therefore, you will see a higher concentration. You will see a higher concentration of PAH in the renal vein. Therefore, the clearance is decreasing. So the clearance will decrease, and it will approach the clearance of inulin, but it will not equal the clearance of inulin. Remember, the 20% that was filtered plus the transport maximum that was secreted will always be excreted and cleared. So the clearance can never reach 0. But once again, the clearance now is close to GFR. So we can use this to estimate GFR. So at very high concentrations of PAH, the clearance estimates GFR, just like creatinine. Again, I use the term estimate because you still have a small amount that you are clearing. Okay, so now we have to talk about graphing PAH. So once again, whenever you're faced with a graph, first thing you should do is look at your x-axis compared to your y-axis. So again, your x-axis here is the plasma concentration of PAH. So you're looking at what happens as the plasma concentration of PAH increases. Compared to what? Compared to the rate. Rate of what? Rate of three things. Rate of filtration, or filtered load. Rate of secretion, because PAH is secreted. And rate of excretion. Now remember, excretion rate is equal to filtered load plus secretion rate. And that's the equation we're going to use to explain this graph. So right here off the bat, as soon as you start to increase the plasma concentration of PAH, the filtered load increases. And the filtered load goes up exponentially. Filtered load is GFR times plasma concentration of PAH. So filtered load increases exponentially. That's your filtered load. Continues to increase exponentially. That's the filtered load. Let's look at the secretion rate. The secretion rate increases and then curves here, tapers off, and then becomes constant. It plateaus. The secretion rate plateaus. Why? Because the carriers responsible for secreting PAH become saturated. They have reached transport maximum. And this is why the secretion rate plateaus. And that's what the secretion rate looks like. Now, the excretion rate. Notice at low concentrations of PAH how steep the curve is for excretion rate. Notice how steep it is. That's because at low concentrations of PAH, both the filtered load and the secretion rate are increasing as you increase the plasma concentration of PAH. And then you have this change in the slope of the excretion rate. Right over here, there's a change in the slope of the excretion rate. You have this little bend in the line over here. So they may give you a question on step 1 where they may point right here to this point in the line, and they may say, what happened here, or why did this happen? Well, this happened because the carriers are saturated. You have reached transport maximum. And now you are secreting at a constant rate. So secretion is now a constant rate. So now as you increase your plasma concentration of PAH, the filtered load still increases, but the secretion rate is constant. So the filtered load still increases, so the excretion rate still does increase, but now it increases at a slower rate. Notice the slope of the line up here is less steep than the slope of the line down here. So notice the excretion rate still does increase. It has to increase, but it increases at a slower pace than it does before transport maximum. So the rate of increase decreases because your carriers have become saturated. And that's why you see this change, because your carriers are saturated. So that's what the excretion rate looks like, and that's what they may give you. So for step 1,
they can give you this excretion rate, just like this. They can say, here's the excretion rate of substance X. They'll draw this out, they'll give you a graph, and they'll say, here's the excretion rate of substance X. Which of the following is substance X? The answer is PAH or creatinine or something that is secreted. And then remember what the excretion rate looks like. The excretion rate will start down here. It'll be 0, 0, 0, and then start to increase somewhere over here, and the excretion rate will increase and increase. So remember what the excretion rate for a substance that is reabsorbed would look like compared to a substance that is secreted. So that's something they can give you on the exam. Another thing I've seen in the exam is they can give you the secretion rate of PAH. They can draw the secretion rate and give you, here's point A and here's point B. And they can say, as you move from point A to point B, which of the following will decrease? Well, you know it's not secretion rate because you're constant. You're at transport maximum. You know it's not filtered load. The filter load has to increase as the plasma concentration increases. You know it's not excretion rate. The excretion rate has to increase as the filtered load increases. The answer is clearance. The clearance has to decrease because once you're secreting at transport maximum and you increase the plasma concentration of PAH, you have to decrease the clearance because you cannot clear anymore because you're saturated. Okay, so this is the graph of PAH, and you may see this on the exam, so make sure you are familiar with this graph and why you have these changes. And that's the excretion rate graph of PAH. Calculating renal blood flow. This is an equation that you should be familiar with for step 1. Renal blood flow is equal to renal plasma flow over 1 minus hematocrit. So what they might do here is they might make you calculate the effective renal plasma flow using the clearance of PAH, and then they'll give you the hematocrit and have you calculate the renal blood flow. So be familiar with this equation because they may ask you to calculate. Now, if they tell you the renal plasma flow is 600 milliliters per minute and the hematocrit is 50%, you could just simply double the renal plasma flow and the renal blood flow will be 1200 milliliters per minute. So this is an equation that you should be familiar with. Okay, so graphical representation of important solutes. This is something you should be familiar with. Let's go through each one. So here's your nephron. A would be something like albumin, which is not filtered. B would be inulin. It's a substance that is freely filtered, not reabsorbed, not secreted. And that's what inulin does. It's not reabsorbed, it's not secreted. C would be a substance that is partially reabsorbed. C would be something like potassium, sodium, or urea. C would also be glucose in a poorly controlled diabetic. It's reabsorbed, but you're past transport maximum, so it's not completely reabsorbed. It is reabsorbed and it is excreted. So C would be a poorly controlled diabetic as well. D would be something that is completely reabsorbed like glucose in a non-diabetic. Notice it's completely reabsorbed. There's nothing excreted. The excretion rate here is 0. E would be something like PAH at low concentrations. It is filtered. It is completely secreted. And the clearance here is equal to the renal plasma flow. The entire renal plasma flow is cleared. And if you look in the renal veins, concentration is 0. The entire renal plasma flow is cleared. That would be PAH. F would be a substance like creatinine, where the renal or PAH at very high concentrations. This would also be PAH at very high concentrations, where you are past the transport maximum. So you're filtering, you are able to secrete the transport maximum, but your carriers are saturated, so you're not secreting the entire renal plasma flow. And if you look in the renal vein, you will see a concentration of the substance. So the clearance is low here. So you're reabsorbing, you're secreting, your excretion rate is higher than your filtered load, and your clearance is low. So that would be substance like creatinine or PAH at high concentration. So this is some graphical representations of renal handling of important solutes.